All right, good afternoon. Welcome to Grand Rounds. I just have a few announcements. As you guys see in the intro slides, on April 2nd, we have the resident invited Grand Rounds speaker, and the speaker is Elko Vijdix from Mayo. And on April 9th is our second annual Spence lecture, and our speaker is Mike Niedergaard from Rochester and Copenhagen, and so hopefully you guys will be able to come. Today, it is my job to introduce Kathy Mathews. She is a professor of pediatrics, and she is the director of the Division of Pediatric Neurology at the University of Iowa. Her current academic efforts have been focused on improving the quality of care for patients with neuromuscular diseases. She has an active interest in the impact of molecular genetics on neuromuscular diseases. She served on NIH and CDC working groups to define a direction of research on neuromuscular diseases in the future. And she's currently a co-PI on the Iowa MD StarNet project, a CDC-sponsored Duchenne and Becker's muscular dystrophy surveillance and epidemiology project. She's also the PI on the project 2 of the University of Iowa NIH-funded Wellstone Center. She is working on defining the phenotypes of patients with dystroglycanopathies, and as a step to setting up a clinical trial to help treat these patients. And interestingly, her son Alex is a neurology resident, and despite our best efforts, is staying at Washington University for his neuromuscle fellowship, so that's our loss. But today, she is talking about the dystroglycanopathies, muscular dystrophy meets glycobiology, and we want to thank the Wellstone Center for help co-sponsoring today's talk. So, Kathy, thanks for coming.
So thank you, Leo. It's a great pleasure to be here, and I've had a lot of fun meeting people that I know and meeting a few people that I didn't previously know. Aha. I added the parenthetic statement here, which is critical for the rest of the talk. This is a group of neurologists. I am not a glycobiologist, and so there's going to be a heavy emphasis on the muscular dystrophy part of this title. So in terms of disclosures, I'm on several advisory boards. I have the research funding that Leo mentioned, and clinical trial funding from a variety of sources, none of which are overlapping with anything I'm going to talk about today. And what I am going to do today is give you an introduction on to the biology of the dystroglycanopathies, talk a little bit about sort of clinical take-home messages and cases, and then very brief, where are we going? So before I can start that, I have to tell you how I ended up here in Seattle today. Leo thought that he was adequately embarrassed with the last talk, but no, he was not. So I met Leo a couple years ago in Amsterdam, and this is Leo climbing the stairs in this windmill. And we were in Amsterdam in April, and I had stayed an extra day, and I think he had early also, and I was committed to going out and seeing all these gorgeous Dutch tulips, and that year it was too cold and it was too early to see tulips. So I was in Amsterdam in April and there were no tulips. And Leo heard about this problem and Leo said, no problem. We'll have you come to Seattle to see tulips. And I said, Seattle has tulips? And he assured me that yes, Seattle has tulips. So I am now here, and it turns out, I think there was a great deal of karma in all of this. Rumor has it that there are tulips now. And I was originally supposed to come like a month and a half from now, at which point there would have been no tulips. But through a series of scheduling conflicts, we ended up with this date. And so I think the gods of tulips are looking out for us and have me here in Seattle so I can see the tulips I didn't see in Amsterdam. Now, I think Iowa also has tulips, but that's and for the perfect timing. So as he mentioned, I'm going to be talking about things that have come out of our Wellstone Center. The co-PIs of our Wellstone Center and my very good friends and colleagues are Kevin Campbell and Steve Moore. We have been meeting at least every month for over 20 years. When Steve first came to Iowa, I was a pediatric resident and I was his children's pediatrician. So we have a very long-lasting and personal relationship. This is a diagram of how our Wellstone Center is set up. Project 1, which is in Kevin Campbell's lab, is translational laboratory research. Project 2 is the clinical study that I'm going to be talking about some today. There's a muscle disease neuropathology conference where we meet at least once a month and talk with everybody in Kevin's lab, Steve's lab, clinical fellows, and we talk about interesting cases. And those are often very interesting and educational. And then 3 cores. And some of what I'm going to be talking today was work done by our Wellstone medical students. So each of these people is a medical student who spends a year with me. And they all do some sort of a project and also are in clinic with me. Every single clinic, they see a bucket load of patients and they get really good at writing notes. I have these first-year medical students writing 6 or 7 notes a day. But they're really good at it by the end. So they've just done a phenomenal job. So the goals of our clinical project, were originally to identify and genotype dystroglycanopathy patients. And the first 5 years of our Wellstone, we were just focused on patients with mutations in FKRP. And then in the last 5 years, we've expanded it to other forms of dystroglycanopathy, to explore outcome measures for future clinical trials, and to define natural history for different genotypes. So, background and introduction to the biology of the dystroglycanopathies. And because this part's boring, these are the patients. This is why we do all of this, so hang in there for the boring part. I used this slide in the earlier talk, but some of you weren't here. So this is how I think of myopathies. Reminder that all myopathies are not muscular dystrophy. And we're going to be talking about the muscular dystrophies. We're going to be in the subset of muscular dystrophies that are membrane related to membrane repair and maintenance. And so the small subset, which is the dystroglycanopathies. This is another way of looking at muscular dystrophies related to the cell membrane. And we're going to be focusing on the group here in red that are due to abnormal glycosylation of alpha-dystroglycan. So what are the dystroglycanopathies? They are a clinically heterogeneous group of muscular dystrophies that result from hypoglycosylation of alpha-dystroglycan. All of them are autosomal recessive, and you may see them referred to in the literature as secondary dystroglycanopathies because the primary mutation is not in alpha-dystroglycan, but adding the secondary onto an already long word is unnecessary, so henceforth I call them the dystroglycanopathies. And many people do. So alpha and beta dystroglycan are formed from a single gene called DAG1, single propeptide that's cleaved into these 2 sections. Beta dystroglycan is a transmembrane protein. Alpha dystroglycan is extracellular. Beta dystroglycan hooks to dystrophin. Alpha dystroglycan connects to ligands in the extracellular matrix. You lose that linkage and you get disease. So glycosylation. Glycosylation didn't exist when I went to medical school. When I first started doing this, I thought it was because I must have missed that lecture. It's possible that happened. But I know that I didn't get a lot of training on it. And then I finally read a review that said, really, there wasn't much known until about 15 years ago. Well, I'm much older than 15 years. I went to medical school much longer than 15 years ago. So it's true, glycosylation didn't exist back then. It's new, and so I've had to learn it post-medical school. The way I think about it is not the way a glycobiologist thinks about glycosylation. I think about it the way a neurologist thinks about glycosylation, so that's what I'm going to be giving you. So there are multiple different, so glycosylation is a modification that occurs on virtually every cell membrane or proteins on virtually every cell in our body. And the various forms of sugar groups that are put on these proteins have major impact on function, and different kinds of sugar groups can result in different functions from a single protein. So it is a huge area of human biology. There are multiple types of glycosylation. The two that are of interest to neurologists, at least my brain's interest to neurologists, there are N-type glycosylations where you have a glycan attached to a nitrogen that should be, or the nitrogen of an asparagine or arginine. And when you have the N-type glycosylation defect, those are the kinds of things that result in the congenital disorders of glycosylation. So those of you who are pediatric neurologists know that there are, 15, 20 different kinds of congenital disorders of glycosylation. They're multisystemic diseases that often involve the nervous system, but they involve multiple systems. You make that diagnosis by sending isoelectric focusing test for transferrin, and you find abnormal glycosylation. That is not what we're talking about today. Different. So what we're going to talk about is O-type glycosylation defects, and this is where the glycans are attached to hydroxyl oxygen of serine or threonine in the case of the diseases I'm talking about. So it's a different kind of linkage, and they are distinct clinical disorders for the most part. And as a result of O-type glycosylation defects, you get muscular dystrophy and or other defects or developmental defects, and I'll tell you about those. So glycosylation takes place through the secretory pathway. This is a diagram that Rita Barisi did in 2000 from a paper that she wrote in 2006. So the number of genes is not where we are now. So the protein makes its way through the endoplasmic reticulum and the Golgi apparatus up to the cell membrane, and as it does, different enzymes act on it, adding different different sugar groups in a specific order to reach the final glycosylated product that is able to bind to the extracellular matrix. Now I'm going to show you that about 5 different ways. This is the way that originally stuck best in my mind. This is a diagram by Toby Willer. So he does these great little cartoons. This is showing you the exact same thing. This is the endoplasmic reticulum, the original genes acting here to put the mannose on the serine threonine residue. Then we have the other genes that act in this assembly line fashion, ending up with large, so you get this glycan that attaches to the extracellular matrix. And if you have something missing so that you don't get one of those linkages put on, then you don't get the final full glycosylated protein, and you disrupt this linkage. So these were done back when we had 6 genes. We now have 18 genes, and depending on how you slice and dice, some people say up to 20. So this is the current list of genes. Now, those of you who are here for the first talk know that this is the kind of list that makes me want to pull my hair out and start crying. There's no way I can remember all that, so I don't. I do have this diagram posted on my door so that I can remember sort of the general concepts here. So GMPPB is one of the newest genes that's been identified. It's involved in creating GDP mannose, which is required for the creation of DOLP mannose. And at this point, this mannose can either be hooked onto alpha dystroglycan, or you can go into that other pathway, the O-glycosylation pathway. And then you move into the Golgi, where all these other genes act on the mannose. We know that the POMGNT1 pathway is a different glycosyl branch. And we know that large is critical for putting on the sugar groups that large put on are critical for forming that last connection. So you can overcome problems down here if you can put those large sugars on, because they will do the connection. But it's and so there was great interest in that as a therapy, but it's a very finely regulated largulation. If you have too much of this, you actually get disease. If you don't have enough, you get disease. So it's a very tightly regulated enzyme. And some of these, we still don't know the function. Most of them are glycosyl transferases, so they're involved in putting on the next sugar group, but some of them we don't yet know the function. And this is Toby's updated pathway with additional genes involved, and you can see that out here are some that are question marks that we don't know the function for. So that's sort of your introduction to glycobiology. As far as I'm concerned, that's what we need to know as neurologists. So where is glycosylated alpha-dystroglycan found? It's found in the muscle, at the sarcolemmal membrane, at the neuromuscular junctions. It's importantly found in the developing brain and in the developing eye, and that explains a lot of the phenotype. So if you have abnormal glycosylation, you disrupt this link between the alpha-dystroglycan and the extracellular matrix. You get muscular dystrophy virtually all the time, and then you may, depending on the nature of the mutation and how it affects the glycosylation, you may or may not get a developmental defect of the brain. You may or may not get a developmental defect of the eye. So that's sort of the introduction to the biology, and I'm going to go over some of the things. These are sort of clinical take-home messages about the dystroglycanopathies. So our participants are from all over the United States. This is from November. The numbers are a little bit higher. These are rare diseases. These are not common diseases. So it has not been easy to put together a cohort of patients, and having them come to Iowa has also been difficult. Anybody who's been there, it's two plane rides minimum, snow, ice, all those bad things. So a couple things to point out. Let's see, the years of follow-up, particularly remember I talked about the fact that we started just doing FKRP, so our years of follow-up are going to be primarily FKRP patients, and that is the vast majority, and that is the most common group. It's the gene that's been around, that we've known about for almost the longest, and it's the most common group by far. So much of what I talk about here will be specific to FKRP because I don't have the numbers to say anything really about these other diseases. GMPPB and ISPD are recently identified. We'll talk a little bit about one of those. So the dystroglycanopathies, as you could predict from the biology that I went through with, encompass a huge phenotypic spectrum. And this, again, is sort of the classical, what we thought in around 2006 when Toby did that original diagram. The POMT1, POMT2, and POMGNT1 tended to be much more severe. Fukuyama muscular dystrophy and large, more moderate, and FKRP had a wider range. With additional time and with more cases being reported and all the new genes, it's sort of like this. They can all be anything, and you can't really predict. When you see a patient, you can't predict which of those 18 plus genes is going to be involved. You can have degrees of probability, but you can't predict. The clinical classification has also gone beyond just congenital muscular dystrophy and limb-girdle muscular dystrophy. So this is the current OMIM classification. It's based on a paper from 2007 by Godfrey et al. So they kept Walker-Warburg syndrome, and I'll show you a case of that. They kept muscle eye brain and Fukuyama congenital muscular dystrophy, and then there are sort of decreasing CNS involvement for congenital muscular dystrophy, then limb-girdle with cognitive impairment and limb-girdle without cognitive impairment. And you can see in here how they defined limb-girdle versus congenital. So this was Joey. He was a patient that I saw before we had any genetic testing. You can kind of see here he's propped up, he has an NG tube, he has marked facial weakness, and he's all dressed up for this fancy picture, but he is definitely propped, he's not sitting alone. He had hydrocephalus identified in a prenatal ultrasound. He was profoundly hypotonic throughout his life. He had optic nerve hypoplasia, glaucoma. CK was 2,000 at 3 weeks. He developed seizures at 1 month that were hard to control, and he died just before his 2nd birthday. And the ocular findings in Walker-Warburg syndrome can be virtual. It's all over the map. You can't predict what kind of ocular findings, but any sort of developmental eye abnormality. And this is Joey's MRI, and this is another Walker-Warburg patient's MRI. So Bill Dobbins actually was the one who pointed this out to me. This very characteristic kinking of the brainstem is seen in almost all Walker-Warburg patients. It's not pathognomonic, but it is suggestive. You can see that these brains are very smooth. They have lissencephaly. There was a very interesting study out of France looking at where they have a prenatal pathologist who every prenatal termination of pregnancy for whatever reason is sent to one pathological center. And they took all the patients, all the fetuses with lissencephaly, and I think they eliminated LIS1, and then they looked at what were then the available dystroglycanopathy genes, which were POMT1, POMT2, and POMGN1, and a significant percentage of the remaining fetuses had dystroglycanopathy genes. So the dystroglycanopathy gene should be on your differential for lissencephaly. And the reminder, which I left an eye out, I see in here for the residents, is that I think we see this we're called to the nursery for a hypotonic infant. We see this imaging, we say, done. We know the problem. The child's hypotonic because his brain was really badly malformed, and we don't look any farther. So when you see an MRI like this, it's always worth doing a CK. I sound like a broken record. Do a CK, do a CK. But it's worth doing a CK. It's cheap and it's easy. And if you have a Walker-Warburg patient, the CK is going to be elevated. Right at birth, it's always elevated. Repeat it in 5 days, and if it's still high, consider Walker-Warburg syndrome. This was a 10-year-old Korean boy when I first met him. He was also hypotonic from birth. He sat alone at 11 months. So this is sort of moving up the severity scale here. He had he never walked. He had about 100 single words, which I didn't believe in clinic. And then I went and saw him at camp, and he was just talking a mile a minute. I said, okay, you're right, you talk. He had a muscle biopsy in infancy that we just were told was dystrophic, but we didn't have any information, and there was no muscle left. His CK, when he was 5, we had records where he had moved around a lot, and it was 8,344. And our diagnostic odyssey in him was sort of long. So he was Korean. This was a number of years ago. He was Korean. I asked the parents if there was any chance that they had any Japanese blood. They said, no way on earth. There is no chance on heaven and earth that we have a drop of Japanese blood anywhere in our distant family. I said, okay. And then so I went through all of the known dystroglycanopathy genes. I sequenced fukutin. The Japanese mutation is a retrotransposon insertion that you will not pick up by sequencing. So at that point, after I had done everything else I knew to do, I looked for the Japanese mutation, homozygous. I went back to the family and said, well, some good news and some bad news. The good news is that we have a diagnosis. The bad news is that you're wrong. So, as I said, he was homozygous for this founder mutation. The other thing that was a clue that I was in the right ballpark by doing the dystroglycanopathy genes was the fact that I did an MRI. So the family didn't want to do another muscle biopsy, but this is T1, T2, so he has these cerebellar cysts, which are highly suggestive, possibly pathognomonic of a dystroglycanopathy. So if you see this picture, or if you've got a patient who doesn't want to do another muscle biopsy, and for some reason you can't get the whole 18 genes done, and you want some more evidence that it's worth doing those, doing an MRI. If you see cerebellar cysts, this one our radiologist actually called up and said, I think they've got Fukuyama muscular dystrophy. The radiologist was Japanese. I said, well, no, not really. Again, radiologist was right, I was wrong. So subsequently, at about the same time actually, the carrier rate of the common Japanese mutation was found to be about 1 in 1,000 in Korea. So it wasn't, if I'd known that earlier, I would have gotten here a little quicker. So next patient is again moving along on the clinical phenotype. This is a 17-year-old male who was in excellent health. In 8th grade, he said his legs got sore and tight after exercise. 9th grade, he reported that he had reddish-brown urine associated with this exercise-related muscle soreness and fatigue. And so they sent him to urology. The urologist said, "You're fine, your kidneys were fine." And so he went back to doing all his normal things. And when he was 17 years old, he was actually sent for evaluation because he was having worsening exercise intolerance and fatigue. He's now 26 years old. He works full-time. He has normal strength on manual muscle testing. So he had a CK during an episode of muscle soreness and fatigue of 52,000. Later in clinic, it was 7,000, but persistently elevated. This is his muscle biopsy. It's dystrophic. And this is Steve staining for dystroglycan. So up here you have, this column is the controls. This column is the patient. This is dystrophin as a staining control. And I don't know, can you see these? Do we need the lights down? Okay. This is going to be a little tough, but in this you can see that there is staining, but it's decreased, and this is typical of what we see in the dystroglycanopathies. So he was found to be a compound heterozygote for this relatively new gene, GMPPB, and we recently pulled together a series of GMPB patients with GMPPB mutations, and I just put these two are both my patients, put them in here for your comparison. So these are one gene. This is the patient that I just presented. He was active in weightlifting and sports, and this patient, also my patient, is now 13, nonverbal, severe intellectual disability, optic atrophy, strabismus, gastrostomy, scoliosis, and an abnormal MRI. So one gene, again, you can get the full range of phenotypic spectrum. And as I mentioned, you can't predict genotype by phenotype among the dystroglycanopathies. So another sort of clinical take-home point is that a metabolic presentation is relatively common and possibly more common in this group than in other forms of muscular dystrophy. So I'm going to talk briefly about 3 potentially overlapping presenting phenotypes. So back when we first started doing this, one of the things that we did, because we really didn't know a lot about these patients, is we had everybody, as part of their intake, we had them fill out a list. We gave them a list of every kind of symptom we could think of, and then room for them to write more of their own, and we said, check all that apply. And I was struck by the number who chose muscle pain and cramps and the number who reported myoglobinuria. And this is out of a very small number of patients. This was shortly after we started doing the study. And so then we went back and formally asked every single patient, have you ever had disabling muscle pain and cramps? Have you ever had Coca-Cola colored urine, tea-colored urine, myoglobinuria? And what we found was that 60% reported muscle pain and cramps severe enough to affect their daily activities. It was almost always exertional pain, and often was started in childhood. And the point of this is that about 30% reported muscle pain as their first symptom, and the muscle pain is in red, and it often was many years before they were diagnosed with a muscular dystrophy. And it was typically almost always onset before age 16. So muscle pain, myalgias, exercise-induced muscle pain is one presentation. Myoglobinuria, this is so 27% of our initial cohort with FKRP mutations reported at least one episode of myoglobinuria, and about 21% of our current cohort, so we're hanging right in there. A quarter of patients will have had myoglobinuria on at least one event. And I want you to look at the precipitants of myoglobinuria, and this sort of tells you something about these patients. Swimming, skydiving is in there, yes, skydiving, square dancing. These people are very active, and these 2 patients who reported too many to count episodes, one of them said that when he was in gym class, he noticed that if he had a really good workout, his urine would turn brown. So I think he was a wrestler or something. and if he, or weightlifter, and he sort of used that as a guide for whether or not he was doing a good job. So if he, went and he worked out and then he went and peed, and if it was yellow, he went back to the gym and worked out some more until it turned brown, and he did this for years. Like, oh my, so it's an interesting, sometimes some of our colleagues, like, they see, oh my gosh, they're having myoglobinuria, admit them to the ICU immediately. And then you get this kind of a story and you think maybe we're over-treating some of these patients. I don't know. So myoglobinuria is a fairly common presenting symptom in this group of diseases. And then there's this acute decompensation. These are 3-year-old twin girls at their first ballet class. They're shockingly cute. This is the reason I'm a pediatric neurologist, for those of you who are adult doctors. So they had early milestones normal. They didn't walk independently until 27 months, but nobody got very excited about it because there was a family history of late walking, so nobody worried about it. And they were developing fine in every other way. So when they were about 2.5 years old, both girls had viral illnesses, nonspecific runny nose, low-grade fever. They recovered in 5 days, and then about 2 days later, both of them became profoundly weak, to the point that they were admitted to the local ICU because of this profound weakness. Their CKs, the local lab only measured up to 20,000, so above that they just said greater than 20,000, so their CKs were greater than 20,000. They were monitored locally. They were in the hospital for about 5 days. They gradually improved. Their CKs came down, and they recovered well. So they continued, the local folks continued to follow their CKs, and they remained around 2,000 to 4,000 over several months. And so they consulted with genetics, who did this extensive metabolic workup, all of which was normal. And this is a classic story. We have now heard this story over and over again. So 12 patients. We think that we've had, I just done a real casual count, like going down the names and recognizing them. I came up with 12 patients who've had it, but it's a very stereotyped scenario. These girls have LGMD2I. At age 3, they had entirely normal exams, so they had come back entirely to normal. Their CKs are still elevated, but they are not weak, and they have normal MRIs. So this acute decompensation with viral illness is reported in Fukuyama muscular dystrophy due to fukutin mutations, and there's at least one report that they typically will use a short burst of prednisone in the setting of this acute decompensation, and it may shorten the period of weakness. I think that it crosses, we've had 8 patients, just on this quick count, 8 patients with 8 FKRP mutations, 2 fukutins and 2 POMT2 mutations who've had this classic phenotype. One mother has a videotape of her son, one day sitting in his high chair feeding himself, and the next day unable to hold his head up, slumped over in his high chair, and in the hospital, sky-high CK, and that was prior to diagnosis by several years. So this very metabolic-looking picture, which I don't understand. So this metabolic presentation is relatively common in this group. It can be muscle pain, myoglobinuria, or this acute rhabdo in the setting of viral illness in a young child. Genotype does have a strong influence on phenotype, details still being sorted out. So I've said before that when I have a kid who comes in and I think they have a dystroglycanopathy, I can't tell you which gene it is. But within a genotype, individuals tend to follow a similar pattern. And there are some mutations that are clearly more benign than others, and that's what we're still starting to sort out. So there's a paper that we just submitted on this GMPBB that we've identified 2 mutations that seem to have, across published cases, in our cases, seem to have a consistent phenotype. And then I'll talk a little bit about this FKRP common mutation. So this is another one of these sort of quick and dirty things. Every patient who enrolls, we have them do this standardized activity. This is just sort of for fun. But we have them do a standardized activity report. It's a validated form that's been used in exercise physiology and general lifestyle health sorts of things. And this is sort of the first time we see them. And so in FKRP, there's a founder mutation, CA26A, that is very common in the Scandinavian population. And so their homozygosity for this mutation is very common. It is clear that this is a relatively benign mutation relative to some of the other mutations in FKRP. So if you divide self-reported activity, and down here this is pre-kindergarten, kindergarten, grade school, junior high, high school, adulthood. So we just sort of clump it, and then they self-report how active you were. And I think it's just amazing that no matter how many patients we add in, the homozygotes, that group who also were skydiving, square dancing, swimming, working out with weights, and developing their myoglobinuria, are more active than the heterozygotes, who are more active than all other genes. So the other genes are more likely to be the more severe cases. And then we also looked at when we had SIBs and we were able to, and we've done all this standardized testing, so we put patients through a whole battery of standardized outcome measures. And so when we had SIBs who we were able to match pretty closely for age, then we looked at across all the outcome measures that we had done. And you can see that they tend to fall right on the line of perfect concordance. These two were less concordant for age, suggesting that the genotype has a pretty strong influence on the phenotype. Now these are SIBs, so their environments are also the same, but we're not getting widespread here. The muscle weakness is slowly progressive, and it's a limb-girdle muscular dystrophy. Surprise, it affects the limb girdles. But this is taking all of our manual muscle testing results across all of our patients in multiple visits, and just sort of graphing where they stand by age group. So you can see that the hip flexors and hip abductor group improves here early on. Somewhere around adolescence it goes down, and then it's really pretty darn stable but weak. Neck flexion improves initially, then is weak and stable. Triceps and ankle dorsiflexion are both spared far into the disease. So there's a pretty stereotyped pattern of weakness that is typical of the limb-girdle muscular dystrophies. We've just started looking, really sort of nailing down some of these outcome measures, the whole slew of them. I've sort of done okay, I have enough patients, I'm going to quit just collecting. We actually have to look at it. So what I have up here is very preliminary. We're still cleaning up data, but it gives you an idea. So these are individual patients that we have more than 3 measurements for, and then divided into those who are homozygous for the common mutation versus the compound heterozygotes. And so you can see that there's a fair amount of variability. This is average MRC score. This is sort of what you see. It's not a perfect test, but there is a general slow decline. And then when we looked at time, and that the 2 curves appear to be different. When we looked at the time function test, 10-meter walk, this is annual change. The amount of time it takes to walk 10 meters, they lost about 0.5 seconds per year. Time to climb 4 stairs took about 0.6 seconds longer each year. And the 6-minute walk distance, they lost about 6.4 meters each year. So what that tells you is these are pretty darn slow. Interestingly, these are similar to what is reported with Duchenne. This one is quite a bit less than what's reported with Duchenne, and I'm not sure why we have that huge discrepancy. This is once we get this data cleaned up a little bit, this is the kind of data that will be helpful in planning clinical trials. So like every neuromuscular disease, I think management involves many, many systems. I'm just going to talk about 3 here, and all 3 of these are areas that patients want to know, doctors want to know, or we identified that patients were complaining about. So alpha-dystroglycan is expressed and glycosylated in the heart. We're not surprised. There's cardiomyopathy. We know muscles of respiration are involved in almost every other neuromuscular disease. Why would they not be here? And so we wanted to look at that. And then smooth muscle, I'll talk about for a minute here. And there currently is no specific treatment for this group of diseases aside from standard management of the symptoms and progression like we do with all diseases. So this is something that Katie Lutz did now a couple years ago, and she's a pediatric resident now, so we're a little bit slow on getting anything written. But we reviewed 118 echocardiogram reports, got all the echocardiogram films that we could, had our cardiologist review all the films, did a correlation coefficient or reliability coefficient, determined that we were in the acceptable range with the reports, and then looked at onset of cardiomyopathy in this across genotypes originally. And in this set, we had 35% had at least one abnormal echocardiogram, and the mean age at onset of an abnormal echocardiogram, mean age at first abnormal echo was in the 20s. And that's pretty much consistent with what's in the literature, where it's a little bit all over the map. Different series range for LGMD2I with FKRP mutations. It ranges from 18% to 60%, so our 35% is probably in the ballpark. Respiratory function, this is, let's see, yeah, so when we just looked at, I'm going to show you forced vital capacity curves, but when we just looked at how many people had a sitting forced vital capacity less than 50%, based on the ALS literature, sitting forced vital capacity less than 50%, you at least think about offering non-invasive ventilation. So we had 9% of our LGMD2I population who fit that criteria, and of those who could cooperate with the other mutations, it was 17%. And again, looking at the literature to see are we in the ballpark, the numbers are not good. LGMD2I, this one looks high. This one, 55% with FK with forced vital capacity less than 50%. We may be low on our population because patients have to travel to Iowa. So those who are profoundly weak will have difficulty traveling to Iowa. But of those that we have, if we're thinking about using FVC as an outcome measure, we're probably not going to be looking at the population or as part of an outcome measure. If we were doing a clinical trial, we're not going to be looking at a population that is so weak and ill that they are unable to travel. So this is probably an okay patient population for thinking about outcomes. And you can see that there is a very slow decline. Once you go below 80%, it seems like people fall pretty quickly. But most people stay for a very long time up here above 80%. And if we looked at the whole population, the annual decline was a loss of 0.8% per year. Not going to be a very responsive outcome measure. And this, again, I did just for fun. So this is graphing percent predicted forced vital capacity against our self-report of hours per day sitting. And the sort of interesting thing is that there is not a perfect correlation. We looked at this in a variety of ways, but this is sort of a good visual. People who are spending up to 20 hours a day sitting are still having forced vital capacities greater than 50% of, greater than 80% of predicted, which is the normal range. So there is not, you can see there's sort of a trend that the more hours you spend sitting, the lower your forced vital capacity is, but it's by no means 100%. So further evidence that this isn't going to be a great outcome measure first, and secondly, that when we see these patients in the clinic, you can't predict forced vital capacity by whether or not they're walking well. Final area is smooth muscle dysfunction. So this came out of talking to patients. So we have these patient conferences and where we see a whole bunch of patients in the course of a very few number, in the course of about 2 days. And it seemed like, as I talked to all these patients, that a lot of them were complaining of voiding problems or dysphagia. And that wasn't part of our usual sort of clinical management. So we developed a survey tool based on validated studies from GI and GU studies. These were Likert scales, and then we converted those to numerical scores. We involved only those who were toilet trained and over 4 years old, and then we invited healthy household controls to participate. So we had about a 52% response rate. We had a small number of household controls. They otherwise were reasonably well matched. And what I'm going to show you is that, so the red is the dystroglycanopathy group. These are the scaled scores, and I think it's easier to see on the scaled scores that the dystroglycanopathy group had more symptoms. This is urinary symptoms. These are the urinary symptom scores. They tended to have more urinary hesitancy, more episodes of voiding, and then feeling like their bladder is full, they need to go back and void again, and weaker intermittent stream. Dysphagia was the other thing. We also looked at constipation, various other GI things. None of those things were significant, but the urology study, the urology symptoms and the dysphagia were significantly different between the dystroglycanopathy patients and controls. We also asked them how much this symptom, for each symptom, we asked them how much does this affect your life, again on a Likert scale. And I didn't put that in. So there was a direct correlation between their symptom score and how much affected their life. So the people who were symptomatic with these things it was affecting their life. And a lot of these symptoms are manageable with medicines. Almost none of our patients were taking any medicines for these urologic symptoms, or the dysphagia is less going to respond to medicine. Most of them had not really talked about these, but they were negatively impacting their life, and they're things we can do something about. So the take home of the clinical management, I monitor with an echocardiogram every 2 years. That's my style. And I put most of my patients on a prophylactic ACE inhibitor fairly early on. I know Beth McNally does that with her dystroglycanopathy patients. I think that's a style issue, but the ACE inhibitors are pretty darn benign. I start them early. I know that a high percentage are going to develop cardiomyopathy. What do we do if we find a cardiomyopathy? We start an ACE inhibitor. Why wait until you find a cardiomyopathy? So I do that in both these patients and in my Duchenne patients. Monitor closely for respiratory insufficiency, consider bicarb cough assist, all those things, and then ask about avoiding dysphagia. These might be treatable, and we can potentially improve quality of life. So, future directions, further phenotypic definition in the non-FKRP patients, better outcome measures for the more severely affected patient, and I'm exploring doing telehealth with the severely affected patients so we don't have the travel problems. Continuing to explore genotype phenotype. We're working with an investigator in Germany to do serum markers for progression, so a biomarker study. Developing tools to verify the pathogenicity of gene variants. This goes back to my previous talk, working with Dr. Moore to try to develop tools that can verify that are cost effective and can tell whether or not a variant is abnormal. And then there are therapy trials on the horizon. There are mouse studies looking at gene therapy. There's a lot of discussion of steroids. I do not put my patients on long-term steroids. And potentially other therapeutic things. A lot of labs are doing screening for new therapies. So I think there's a good chance that in the next 5 years we're going to be doing treatment trials and hopefully having more to offer this group of patients. So I'd like to thank my colleagues at the University of Iowa, all the patients who have continued to educate and inform me and participated in doing these laborious evaluations, the colleagues who referred the patients to us, and then to Leo for inviting me to this lovely city and getting to talk to you. Thank you. Yeah.
With the poor genotype phenotype collection, do you think there's like a strong influence of environmental factors?
That was actually on my initial application. It was to try to look at environmental factors, and that's part of the reason that we did that SIB-SHIP correlation. So some of these SIBs are adults and are now in different environments. So it's possible. I don't think we know yet. There's certainly not been anything that has jumped out in our in-depth discussions with all these patients. Yeah.
What about aminoglycoside treatment, the possibility of using it?
Well, I mean, we're not doing it in Duchenne where there's good animal work. So I guess I'd like to see something, I'd like to see it work. So PTC, basically, some sort of a read-through approach for or missense mutations. I think that if the PTC study is shown to be effective in Duchenne, that it will be, that would be a viable consideration for a lot of these mutations. Let's get the results first. Yeah.
So if we're seeing a patient and do a muscle biopsy and it looks dystrophic, and we do an alpha dystroglycan immunohistochemistry screen, is that good enough to rule out this class of diseases or not?
Very good question. I think my answer would be it would depend on whose hands did it. And I would say certainly not 100%. If Steve Moore looks at it, we have a commercial antibody and then some other antibodies that are not widely available that come through the Campbell lab. If Steve Moore looks at it with several antibodies, says this is not a dystroglycanopathy, I think there's a high probability that is correct, but probably not 100%. Yeah.
We end up seeing a lot of patients with similar complaints of exertional myalgia and exercise intolerance.
So do we.
So my assumption and how I work a lot of these patients is I put a lot of weight into the CK. So I wonder if you've had any of these patients that have had a normal CK at some point.
No, I also put a huge amount of weight on CK. I will not go this, if their CK is not greater than 1,000, I will not go this route.
So I was interested in the cerebellar connection that you mentioned, and that one very young baby with huge hydrocephalus looked like there was cerebellar agenesis,
yeah.
like no cerebellum. So in the older cases, can it be mild, and do they ever have any cerebellar symptoms?
No,
Or signs?
not that I've ever seen.
So what do you think is going on there? That the severe ones, the cerebellum is gone practically, and the older ones, nothing?
You know, I think it's like the rest of the brain developmental abnormality. I think it probably has to do with the amount of glycosylation in like Bergman glia and the glia limitans, and whether or not you have abnormal migration. And if you have enough glycosylation, you're probably protected. And you might have, there may be subtle abnormalities that we don't see, but this is the way the brain is made. The severe ones, I don't think we see any cerebellar signs because they're non-ambulatory, they don't do much. But it is an interesting brain phenotype. Okay, thank you very much.